So welcome to the week 6 lecture on disorders of iron metabolism. And as usual, we will go through the different types of disorders that you need to know about, and also we'll finally learn in depth about these famous iron studies and the tests that are included in that that overall suite of tests. So we've got 4 learning objectives for this lecture, or for this learning module, and it's going to also interpret, identify individuals and interpret laboratory results, as well as looking at iron studies tests and differentiating the disorders, as I said before. So I'll just turn off my webcam now. So if we have a review from week 5, we can recall that microcytic anemia comes about by a quantitative decrease in hemoglobin synthesis. So this is true for microcytic anemias overall, so due to iron deficiency, as well as our thalassemias, where we've got that quantitative decrease in hemoglobin synthesis. So we don't have as much hemoglobin there. And it's hemoglobin that fills the red cells, because that's the red cells' function, is to house hemoglobin, to protect hemoglobin, and to transport it around the body. So if you don't have the complete amount of hemoglobin that you should have, then the cells are going to be smaller. So when we're looking at causes of hemoglobin abnormality, I guess you've got to remember that we have got the globin part, which we looked at the abnormalities of the globins last week, and this week it's the abnormality of the heme part. So iron dysregulation, so whether it be incorporating iron into the heme disc, into the protoporphyrin ring, or whether it be a deficiency of iron, so there's not enough iron to actually be put into the ring and to make the heme part of hemoglobin. And so we've already, as I said, we've already talked about impaired globin synthesis and disordered or defective globin structure. And this week it's all about impaired heme synthesis. And this is just a reminder that our iron deficiency anemia that we can see is down here. Here we go. Iron deficiency anemia is part of the microcytic hyperchromic anemias. You can see here that they've also got sideroblastic anemia, which we talk about actually being a normocytic anemia. So there's a little bit of differences between what is in Mackenzie and what I've always believed, but it's neither here nor there really. And this is just a really simple way in which to categorize the lots of different causes of anemia that we have. And as with everything in haematology, it's not cut and dried. You do get crossovers with things. And you'll see when we're looking at other causes of abnormal iron metabolism, that a number of them are actually normocytic. But of course, iron deficiency sits in our microcytic hyperchromic group, as do our thalassemias. So again, you'll find that Mackenzie classifies sideroblastic anemia and anemia of chronic inflammation as microcytic anemias. And when we come and have a look at them today, you'll actually see that they are more commonly presented with a normal MCV. And so, as I said, I've got it slightly differently organised to the way that Mackenzie has it, but it doesn't really matter. So we can see here that really iron deficiency anemia is the only microcytic hyperchromic disorder of iron metabolism. The others are usually normocytic. Sometimes anemia of chronic inflammation can present as microcytic, but that's often because the people with anemia of chronic inflammation also have an iron deficiency as well. So it's a bit of a double whammy for those people. So here's a bit of a review for you. What I'd like you to do is just to have a go at filling in the blanks that you see here. So this is our endothelial cell, which is lining our gut, and we've got iron from our food being absorbed into the endothelial cell, and then it's being transported out from the cell into the plasma and travelling around the plasma, and then it's stored in the bone marrow and in the liver. And then of course there's something that actually blocks the absorption of iron, or the release of iron into the plasma from the duodenal endothelial cells. So see if you can work that out, and I'll give you a minute to do it. Okay, time's up. Let's see how you went. So we have our divalent metal transporter 1 here, which transports ferrous iron into the mucosal endothelium. And then we have ferroportin, which transports the iron from the endothelial cell into the plasma, where it is oxidized to ferric iron and then is bound to plasma transferrin. So that's the plasma iron transport protein, and it is as transferrin that iron is carried to the erythroid marrow and also to the liver, where it is stored as ferritin or as haematology2, and also to other cells in the body, because most cells in the body use iron in some form or another. But of course, in haematology, we see the effects of iron dysregulation in the blood cells. And of course, hepcidin is the protein in the liver which blocks the action of ferroportin, so that no more iron can be released from the mucosal epithelial cells, or so that iron cannot be released from the reticuloendothelial system macrophages either. So how many got those right? Just put your hand up if you got them all right. Nobody did. Oh dear. Okay. Well, that's something for you to work on. So what we're going to do is we're going to have a look at some of the proteins that we talked about in that previous slide. And of course, the first one of those that we're going to look at is transferrin, because as I said, that is the way in which iron is transported in the plasma, because iron is highly reactive. It's a little bit like a 2-year-old in a lolly shop. It needs very firm handling to keep it in check. So you can see here that apotransferrin is the protein without any iron attached to it, and each apotransferrin molecule has 2 iron binding sites. So we tend just to talk about transferrin, even though sometimes it may be apotransferrin that we're talking about. But transferrin is the form where we have the ferric iron actually bound to the protein. You can see there are 2 active sites, and it is through transferrin that the iron is delivered mainly to the bone marrow and the liver, but also to other body cells as well. And you can see this is transferrin loaded up with its 2 ions of ferric iron, and then it interacts with or binds to transferrin receptor 1 on the cell surface of cells, and then this complex is actually brought into the cell, the iron is removed, and the apotransferrin, as it now is released from the cell. So transferrin is produced in the liver, and as you can see there, it is a negative acute phase protein. So that means, as we learned in week 1, that in times of inflammation we have positive and negative acute phase proteins, and there's a reminder of that here. So because of these inflammatory cytokines, we have what we call positive reactants and negative reactants, and here you can see that transferrin is a negative reactant. So in times of inflammation, the cells in the liver downregulate transferrin production, and so that's something to keep in mind when we're looking at the results of iron studies in people who have anemia of chronic inflammation. Keeping in mind that transferrin production is actually reduced in these people. And we can also see here's ferritin, so that is a positive acute phase protein. So in times of inflammation, ferritin concentrations increase, as does hepcidin. And of course, hepcidin is the enzyme that blocks ferroportin and prevents iron from being transported out of the endothelium of the gut, but also transporting it out of our macrophages as well. So speaking of ferritin, that's the next thing that we're going to be looking at. So all cells use iron in some form or another, and so they're able to store it so that they have a reserve if supplies of new iron decline. But the cells of the reticuloendothelial system and hepatocytes, and also in the bone marrow, store most. So ferritin is the majority of storage, and if you like, that's the short-term storage, and iron stored as ferritin is readily available. Whereas we've got hemosiderin, which is what we have for long-term storage, and you can see that hemosiderin is partially degraded ferritin, and it takes a little bit longer to be able to release the hemosiderin. And when we do, we look for iron stores in the bone marrow, it's actually hemosiderin that we're staining, because ferritin doesn't stain. So using the famous Pearl's Prussian blue stain from histology, that's what's staining up hemosiderin in the bone marrow. And also in tissues, when other tissues are stained to see if they've got any iron in them. And the thing to remember is that there is a small amount of ferritin that is present in the plasma. So even though it is the tissue storage form of iron, there is some that is dissolved in the plasma. It contributes very little to overall iron storage, but it's in equilibrium with tissue ferritin. And so it acts as an indicator of body iron stores, and that's really useful because it's actually the serum ferritin that we're measuring. And so as body stores of ferritin are reduced, so is serum ferritin, and vice versa. When body stores are increased or tissue stores are increased, serum ferritin concentrations increase as well. This is just one of my favourite images that I found over the years. And so this is a picture of a bone marrow macrophage in the middle here, of lots of maturing erythrocytes, and this is referred to as an erythroblastic island. So as I said, in the bone marrow, it is the macrophages within the bone marrow that store iron. They also store all sorts of other goodies too that they impart to the red cells. And so you can see that there are some very, very immature red cell precursors here. So they're much larger cells with very deep dark blue cytoplasm, but we've also got some more mature forms here too. So you can see this is really good because it shows you how the cytoplasm changes colour as the red cells take on more hemoglobin. And then we've got some quite mature cells over here. So these are our nucleated red cells that we sometimes see in the blood. And of course, here is a reticulocyte right next to it. So I think that's a really good picture that shows how the cytoplasm in red cell precursors changes as they take on more hemoglobin. So here are the famous four. So these are the tests that are included when we talk about iron studies. So there are a series of screening tests used to assess iron status in iron deficiency anemia, to differentiate microcytic anemias from each other, and also to differentiate other orders of iron metabolism. So you can see the four tests are serum iron, total iron binding capacity, or TIBC, transferrin saturation, and serum ferritin. And as you can see there, serum iron itself, it's probably the earliest of the tests to have been devised. It's been around for a long, long, long time. But it's a very poor indicator of iron status because there's high biological variation. It's a coefficient of variation of about 26%, which is huge. And there's also significant diurnal variation too. So it varies from morning to night. It is very affected by diet and supplements. And again, this is a negative acute phase reactant. So serum iron itself falls due to the effects of inflammatory markers. And I guess you'd expect that, because if hepcidin is preventing iron from being absorbed from the gut and it's preventing iron from being released from tissue macrophages, then the amount of iron in the plasma is going to fall. And so you would expect the serum iron to be reduced in those instances. So we're going to go on and have a look at the other three of these iron studies tests, the ones that are in red. And we'll start with looking at total iron binding capacity. So the definition of total iron binding capacity is the amount of iron able to be bound in the serum. If you like, it's an indirect measure of apotransferrin. So remember that apotransferrin is the transferrin protein without the ions attached to it. So that's why it's inversely proportional to the concentration of transferrin, because it's if you like, it's the transferrin that hasn't had well, as I said, the transferrin that hasn't had the iron attached to it. So what we're trying to determine is how much capacity is left within the plasma or the serum to take on more iron. The reason that we've had to do it this way is because transferrin is actually quite difficult to measure, and so it was easier to measure the apotransferrin, I guess. And the main reason that we measure total iron binding capacity is because we can then use it to calculate the percentage of transferrin saturation, which is what this stands for. And so that can tell us exactly how much iron is actually bound to the transferrin protein. So as a general rule, changes in the quantity of total body storage iron, so that's changes in the quantity of ferritin, are accompanied by changes in the serum iron and total iron binding capacity. So that means that as storage iron increases, serum iron increases. And that makes sense, really, doesn't it? Because if you've got, if your cells in your body are starting to fill up with iron, then you're not going to be taking on as much iron from the plasma, and so more iron will stay in the plasma. And of course, it's serum iron that we measure. If we've got an increase in serum iron, then that means that our total iron binding capacity is going to be reduced, because that means that more of the serum iron is going to bind to the transferrin molecule, and there's going to be less of the apotransferrin that hasn't been bound. Conversely, when we've got reduced body iron stores, or if they're decreased or they're absent, then of course serum iron is going to decrease as well, because that means that if there's not a lot of iron around, the body tissues are going to absorb as much from the plasma as they can, and so that's going to reduce the amount of serum of iron in the serum, and therefore there is less iron to bind to transferrin, so total iron binding capacity, so the potential of transferrin to bind with iron is increased. Don't forget, you can ask questions anytime, because that can get a bit confusing, total iron binding capacity. So we'll go on and have a look at transferrin saturation now, which is a more, I guess it's a, having said it's more modern, it's been around for a long time. It's just that when I was in the lab, we didn't measure transferrin saturation, but that was quite a while ago. So normally there's enough transferrin present in the plasma as apotransferrin to bind 45 to 80 micromoles of iron per litre. And this is well in excess of requirements, because normal serum iron levels are 10 to 30 micromoles per litre. So these figures are all from the RCPA website that I'm using. You'll notice that the figures are different in your text, because that's an American text. So they use different units of measurement for iron studies, and they may have slightly different reference intervals too. So yeah, I'm using the ones from the RCPA website. So back to transferrin saturation. So as we said, there's enough transferrin present in the plasma to bind 45 to 80 micromoles of iron, and serum iron levels are usually 10 to 30 micromoles. So this means in a normal individual, the transferrin is about 1/3 saturated. So if you have a look at the reference interval here, 15 to 45%, 1/3 is bang in the middle of that. 33 is right in the middle of that. And so usually our transferrin is about 1/3 saturated. So a transferrin saturation that is below 15% suggests that we have iron deficiency, and is certainly a feature of iron deficiency anemia. So you can see here, if you've got a low amount of serum iron, and so then you've got a low transferrin saturation, that makes sense, because you don't have as much serum iron to bind to the transferrin. Conversely, if you've got a percent transferrin saturation of greater than 45%, that's a good indicator of iron overload, and possibly hemochromatosis. But as you can see there, this increased transferrin saturation, you have to take into account when the person last ate a meal that contained iron, because that can affect it. So basically, the higher the serum iron concentration, the lower the capacity of plasma to carry extra iron, because the transferrin is more saturated. And so serum iron concentrations and percent transferrin saturation should mirror each other. So both raised or both lowered. But this is haematology, and it's not always the case, as we shall see. Finally, we're going to have a look at serum ferritin. So until the development of serum ferritin assays, the only way to truly assess body iron stores was to take a sample of bone marrow and to stain it with Pearl's Prussian blue. So because this is such an invasive procedure, we really didn't have regular assessment of body iron. But now, of course, we have an immunoassay that measures ferritin in the plasma. The concentration of serum ferritin has been shown to correlate highly with tissue ferritin due to validation studies done on serum ferritin comparing to bone marrow stores. However, as you can see there, increased ferritin are not a reliable marker of iron stores, because it is an acute phase protein, and so it needs to be, increased ferritin stores need to be read in context with the sort of clinical health condition that the person may have. But the really great thing with serum ferritin measurements is that they have a very high predictive value for iron deficiency. So a low ferritin result has a high predictive value for iron deficiency. So decreased serum ferritin is the strongest, most sensitive and most accurate indicator of iron deficiency. All of those other tests can combine with serum ferritin to help us to differentiate the other forms of iron dysregulation. But serum ferritin is the one that will tell us whether or not we have iron deficiency. Okay, so I've got a poll for you. So if you just bear with me while I set it up for you, talk amongst yourselves if you like. Okay, so here's our first poll. So total iron binding capacity, so that's TIBC, is inversely proportional to ferritin, hemosiderin, serum iron, or transferrin. Okay, and yes, of course, it is inversely proportional to transferrin. Well done. And the next one, oh yes, they would. Yes, they probably are. Okay, so transferrin saturation is calculated from serum watt and serum watt. So we've got ferritin and serum transferrin, ferritin and total iron binding capacity, iron and serum ferritin, iron and total iron binding capacity. And of course, you're meant to be doing these little polls out of your head, not looking back at the slides. Okay, so transferrin saturation is actually calculated from serum iron and the total iron binding capacity. So remember, total iron binding capacity on its own doesn't really tell us anything, and serum iron on its own doesn't really tell us anything. But together they can, and as Brad pointed out, serum iron and total iron binding capacity are usually inversely proportional to each other. But it's the big use of both serum iron and total iron binding capacity is to calculate the percent transferrin saturation. Well done. Okay, let's continue on. So now we're going to have a look at the different conditions of iron dysregulation that you need to know. And you can see that sideroblastic anemia, highlighted in blue there, is classed under iron restriction as well as iron overload. And that's because it's a condition of both, as we shall see, but more to come later on. So first of all, we're going to start with iron deficiency anemia, which is a straight out lack of iron. So we don't have anything crazy going on. There's no abnormal enzymes or abnormal genes or anything like that. It's just, we have a lack of iron. Of course, before we get to that, just a reminder, with all of the different conditions that you have been learning about this semester, there are things that you need to be able to summarise as you're going, so that it makes it easier for you to prepare yourself better for your tests and exams. So iron deficiency anemia. So this should be very common to all of you because we talk about it a lot in both haematology 1 and haematology 2, and also in other units as well. So you should be able to bring all of that information together with you to be able to answer any questions that are asked about iron deficiency and iron deficiency anemia. So as we know, it's the most common cause of anemia worldwide, and it's also the most common nutritional deficiency worldwide. So everything's working the way it should. It's just that for some reason, there is a deficiency of iron to the cells, to the developing red cells in the bone marrow, and also to other cells of the body as well. So it is most commonly caused by iron intake failing to meet the cellular demand for iron. This can be either nutritional deficiency or increased demand, and less commonly due to actual loss of iron in chronic blood loss, some sort of impediment to iron absorption, so something wrong with the gut, or competition for the available iron. So in Med Micro B, for those who are doing micro, you'll learn about hookworm infestation, where the hookworm latches onto the tissue in the gut and feeds off the host's blood. And I guess, if you like, it's almost a form of chronic blood loss. So one thing that you need to understand is that there are actual stages of iron deficiency. So iron deficiency doesn't suddenly happen. It usually happens over a period of time. So it's usually sort of weeks to months that this happens. And I'm going to go straight on to the next slide because I really like the way the graphic works on this slide. So you can see here that there's 3 stages of iron deficiency. So here's our first stage here, which is iron depletion. It shows us what's happening in the body with our iron stores. But it also, down the bottom here, it shows us our hemoglobin and our red cells, but it also gives us what our iron studies tests are doing as well. So when we have a look at stage 1, where we have iron depletion, we've got progressive loss of storage iron. So here's our normal area here. So we've got our storage iron is replete, therefore our percent transferrin saturation is perfect, so it's hanging around 33%, and also our functional hot iron in our hemoglobin is fine as well. So our hemoglobin is within reference intervals for the population. So in stage 1, we get progressive loss of our storage iron. As you can see here, our percent transferrin saturation is fine, although it's starting, as we know, serum iron and storage iron sort of mirror each other. And so as the storage iron reduces, the serum iron starts to reduce, although it really only does that at the very end of this iron depletion stage. Our functional, so our hemoglobin is fine. We're not picking that up in our full blood count results at all. And then stage 2 is where we have iron deficient erythropoiesis. So this is where we have exhausted our storage iron, as you can see here. And so what's happening now is that we're starting to eat into the iron that is being transported, or if you like, is in our plasma, that mobile iron. And we're also starting to eat into our functional iron too in our hemoglobin. But what's happening here is that the hemoglobin content of reticulocytes begins to decrease. And this is, as I said, iron deficient erythropoiesis. And so this results in smaller red cells. And so we get an increased RDW. So why do you think, because our retics are smaller, why is that going to increase our RDW? Anyone have any ideas? So the answer to that is that you have to remember the life expectancy of a red cell, which is quite long. It's 120 days. So we're looking at about 4 months. So if you've got, in that time, you can have red cells that were made when our iron stores were hunky-dory and there was enough iron for normal red cells to be made. But once we get into this iron deficient erythropoiesis stage, the red cells start that are being released are smaller. And so we've got new red cells are smaller, but our older red cells are normal. And so that's why our RDW is on the increase. And this is the thing to remember too, is that the red cells get small before they get hypochromic, which is quite interesting. And it was explained to me a little bit like when you get a pizza delivered, when you say got 6 people in the house, you get 1 pizza delivered, a giant pizza, obviously. But then, a few more people drop in. And so it's too late to order another pizza. So what you do is you cut up the pizza into more pieces. To feed the extra people who are coming in. And so that's a little bit what happens in the bone marrow. Once the iron stores start getting lower, less iron is distributed to each red cell and the red cells get smaller. But there are still very few clinical signs and symptoms at this stage, even though our transport iron and our functional iron are starting to reduce. Our hemoglobin is still normal and our red cells are still normal, but they're getting smaller. So they're still within the reference interval, but it could be that they're at the lower end of the reference interval. Same with the hemoglobin. It's still within the reference interval, but it might be coming to the, to the lower half. And then the stage that we can see in our FBE screening tests is where we have frank iron deficiency anemia. And so this is when we have microcytic anemia with the clinical signs and symptoms of anemia. We have depletion of all iron compartments, so our storage, our transport, and our functional compartments. So the depletion of storage iron and transport iron prevent normal development of red cell precursors, and so that's why we get our microcytic hypochromic cells. And when you have a look here, you can see that hemoglobin is down, our red cells are microcytic hypochromic, and this is where we get our classic iron studies results of a low serum iron, increased total iron binding capacity because they are the inverse of each other, low percent transferrin saturation, and also reduced ferritin. And ferritin is highlighted here because you can see that the only test that is affected in these earlier stages is actually the serum ferritin. So in stage 1, we're able to detect that iron stores are getting low and therefore the person is becoming, is in a negative iron balance. And this is just a pretty slide that shows you exactly the same thing. So I'm all for different ways of showing things. So in A, we've got iron homeostasis, so everything's in the green. In B, this is where we start getting our iron depletion, so our iron stores are becoming inadequate, but we've still got enough iron in our plasma and in our hemoglobin. And then we've got our iron deficient erythropoiesis when we start making our smaller reticulocytes, and then frank iron deficiency anemia. So on this slide, it says that development of iron deficiency anemia has a slow onset that may be months to years. I don't know about any other women of childbearing age, but I certainly know when I was, before menopause, I had to be very careful of my iron stores, and really probably I used to go on an iron supplement probably once a year. Just to make sure that I didn't become iron deficient. And I'm an omnivore, I eat everything. So it is a slow disease progression. And because of that, of course, again, the homeostatic mechanisms in the body are able to compensate. And so again, it's not until we get all of our iron compartments being reduced that we start seeing clinical signs and symptoms, and also signs in our laboratory tests. Of our full blood count screening test, probably the RDW is the most sensitive indicator because it picks up those smaller reticulocytes. So that's something to look out for. But usually that would be a serendipitous finding. So that would be, say, when somebody goes to give blood at the blood bank and they do a check on their, they do a full blood check, and then you might see an increased RDW. And if they go on and do iron studies, then they would see that the ferritin is reduced. So when we have a look at the blood film, you can see that we've got a decreased reticulocyte count, but that's really, it's not the most defining feature of iron deficiency. Of course, it is the microcytic hypochromic anemia that is the most defining feature. The thing with the reticulocyte count, though, is that it increases really quickly in response to treatment. So within sort of 2 or 3 days, you'll get your reticulocyte count starting to come up. Actually, I think it's a bit more than that. I've got a feeling it's about 5 to 10 days, but it's pretty quick. And you'll see in the literature that they say that iron deficiency anemia has polychromasia. Now, the thing with this is that it's not polychromasia because you've got retics. It's polychromasia because you've got hypochromic red cells coming through, as well as your older normochromic red cells. So just be careful when you talk about polychromasia with iron deficiency anemia, because traditionally that term polychromasia means that there are lots of reticulocytes there. So if you're using it to tell me that some of the cells are hypochromic and some of them are normochromic, it's probably better to use those terms and keep polychromasia for when we've got an increase in the retics. Okay, so if you think you've got some hypochromic cells and some normochromic cells, use those two terms. Keep this term for when there are an increase in polychromatic cells within the blood film, because of course we can't actually see retics in a blood film, can we? We can only see retics if we use a supravital stain. We see polychromasia in a blood film. And so here we've got a couple of instances of microcytic hypochromic anemia. And so here you can actually see there is a bit of a dimorphic blood picture here. There's most of the cells, though, are microcytic and hypochromic. In this one, this is a frank iron deficiency. So this is, I would suggest that the hemoglobin is lower in this case than in this case, because almost all of the cells are very hypochromic. And we've seen this comparison of laboratory results before, I think last week when we were talking about thalassemia, because thalassemia is also a microcytic hypochromic anemia, we need to differentiate thalassemia from iron deficiency anemia. And see, you can see here the red cell count. Remember, we were talking about that there's a particular pattern that we see in thalassemia where we can get microcytic red cells, but the red cell count is often normal or increased even. So even though you've got a hemoglobin that might be low, you've got a normal or increased red cell count. Whereas with iron deficiency anemia, the red cell count usually mirrors the hemoglobin. So if you've got a low hemoglobin, you'll have a low red cell count. And here are two of our iron studies tests here. I don't know why they've chosen these two, but there you go. So, of course, in iron deficiency anemia, our serum iron is reduced and our total iron binding capacity is increased, but in thalassemia minor, these are normal. And it's when we get to the hemoglobin electrophoresis that we start to see the abnormalities in thalassemia. Basophilic stiffling is often present in beta thalassemia, and of course it is an inherited condition, whereas iron deficiency anemia is not, or there's no other things that might impact on iron absorption might be inherited, but iron deficiency anemia itself isn't. And again, this is another slide that you saw last week, and I've just highlighted here because it's showing you the assessment of iron status on this lovely little graph, as well as hemoglobin A2 measurement. And this can be done in a number of ways, but it's normally done in a lab through hemoglobin electrophoresis and then densitometer analysis of the strips, of the protein strips. So when we look at the treatment for iron deficiency anemia, usually it is to increase the dietary intake and we can get a 2 to 5-fold increase in our reticulocytes. Oh, there you go. I was right, 2 to 3 days. I don't know why I thought it was longer, but you can get a reticulocyte response within 2 to 3 days and it will rise quite rapidly. So the traditional way of doing it is of treating iron deficiency anemia is with a dietary supplement, but for some people who have a very low hemoglobin or who have a history of poor gastrointestinal tract absorption of the iron supplements, iron infusion is an alternative. And iron infusion is actually getting more and more popular, probably because you get a much faster response, and so the patient's symptoms are treated a lot faster. And then, of course, if there is no response, we would have to do a bone marrow analysis. Some of you will be interested to see, because it could be that there is some other reason why iron is not being incorporated into those red cells, as we shall see later on in the lecture. So before we jump onto there, I've got another couple of learning checkpoints for you. And see if you can answer these without looking back at your notes. This one you should be able to, because it's pretty easy. Says she who only has to concentrate on haematology. Whoops, don't need that one. Okay, iron study test that is the most sensitive indicator of iron deficiency is serum iron, total iron binding capacity, percent transferrin saturation, serum ferritin. Yes, of course, it's serum ferritin. Well done. Okay, and our next poll. So the earliest stage of iron deficiency that's detectable by haematology screening tests is iron depletion, iron deficient erythropoiesis, or iron deficiency anemia. Yes, it is iron depletion. So the serum ferritin, the most sensitive test, can actually detect when we have iron depletion. So when our iron stores are starting to be reduced, because of course that's what serum ferritin reflects, and that is what's happening in iron depletion. Excellent. Okay, so let's get on to the next condition that you need to know about, and that is anemia of chronic inflammation. So we've already talked about this in week 1 as an example of hypoproliferative anemia, but again, it's mentioned here because it is a condition of iron dysregulation. That's actually what causes it. It's the second most common cause of anemia in the world, and it's important that you learn about it. So you can see here that, as we know, the etiology is the inflammatory cytokines that are produced, which have a direct effect on the bone marrow, as you can see down here, and also they're able to suppress erythropoietin production by the renal tubule cells in the kidney, as well as suppressing absorption of iron and also iron recycling. So just as a reminder, so this is a slide from week 1 that shows that. So you can see that inflammatory cytokines have a direct effect on the bone marrow through both depressed erythropoiesis and depressed erythropoietin, but it's interleukin 6 and the effect of interleukin 6 on liver synthesis of hepcidin, and of course that is what prevents iron absorption and also iron release. And this is just another pretty little picture that I found from another paper that I came across, and I think it's quite lovely the way that it shows how the hepcidin actually blocks the ferroportin, and so iron can't be released into the plasma, and hepcidin actually blocks the ferroportin on the macrophages as well, so that the iron can't get out. And this is a couple of images from Mackenzie. So we've got a patient with anemia of chronic inflammation is what I call it. You'll also see it being called anemia of chronic disease, but I think the term inflammation is more pertinent because it's actually those inflammatory cytokines that are doing all the damage. You can see here, so we don't have that much hypochromia. A couple of the cells are hypochromic, so you can see the hemoglobin, that should be 96, of course, not 9.6, 96 grams per litre. Again, this is because Americans use a different system. I changed the MCHC, but I didn't see the hemoglobin one. MCV is 76, is slightly lower than the reference interval, which is at about 78 or 79, I think. So when we do get a microcytic picture with anemia of chronic inflammation, it's usually not that microcytic. And what you can see is a bone marrow, which is showing these are the bone marrow macrophages. So they've got a lot of hemosiderin in them because that has been bound into the cells and it's been degraded. Yes, so there is an increase in hepcidin production due to the inflammatory cytokines release. So it's interleukin 6 stimulates the liver to produce more hepcidin. And because we've got that increase in hepcidin, we have the blocking of ferroportin, so we can't get iron absorption from the gut, and we also can't get any stored iron out of the tissue macrophages. And so the hepcidin blocks that. So that increase in hepcidin blocks that. Thank you for your question. And yes, so there we are. There's our macrophages chockers full of hemosiderin that the red cells can't get access to. So again, these are our erythroblastic islands, and these poor red cells are being denied their iron. Mackenzie has a really good chapter on iron iron dysregulation, and this table is quite lovely. So it gives you to show you that there are a lot of conditions that are associated with anemia of chronic inflammation. Because otherwise we do tend to focus on things like rheumatoid arthritis, but you can see here that any sort of chronic inflammatory condition can cause anemia of chronic inflammation. So here is a comparison of some results so that you can differentiate anemia of chronic inflammation from iron deficiency anemia. So you can see here that anemia of chronic inflammation, the MCV, the MCH, and the MCHC are usually normal or at the lower end of normal, or perhaps a little bit below, but usually they're not too, they're certainly not as low as they can get in iron deficiency anemia. Serum iron can be very low in both cases, so that's not going to differentiate our iron studies, but it's when we get to the total iron binding capacity. So as we said before, serum iron usually is inversely proportional to total iron binding capacity, but in anemia of chronic inflammation, it's not. And this is because transferrin is a negative iron acute phase protein. So remember that in times of inflammation, transferrin production is downregulated. And so that's why our total iron binding capacity is reduced, because we don't have as much transferrin in the plasma. Serum ferritin in iron deficiency anemia is reduced, whereas in anemia of chronic inflammation, it's normal, because remember the ferritin is locked away in the hepatocytes and the tissue macrophages, and it can't get out because ferroportin has been blocked by the hepcidin. So bone marrow iron stores are gone as well. Bone marrow iron stores in anemia of chronic inflammation are actually increased, because any iron that's around is being locked away in the macrophages. And then we get down to hemoglobin electrophoresis. It doesn't really apply here, but our red cell size or red cell number usually is proportional to the degree of anemia in both, but because we don't tend to get really low anemias in ACI, then the red cell count's usually not that low either. The other test that can be used not so much to detect anemia of chronic inflammation, but to monitor it, is the erythrocyte sedimentation rate. So this was mentioned in week 1 when we were talking about hypoproliferative anemias as a fairly non-specific test. It's raised in conditions of chronic inflammation because we have an increase in our plasma proteins. And as I said, it's more checking in chronic inflammatory conditions to see if there's been any flare-ups in any conditions where you get flare-ups, such as rheumatoid arthritis. And so it is a difference in, it is affected by a number of other things as well that can affect it. Anemia can affect it, dehydration, and also polycythemia, because dehydration can affect it because we're losing our solvent, and polycythemia can affect it because we're increasing our solute. And so it's increased, usually the ESR is less, so you've got less falling. So usually it's less than 10 millimeters per hour or something, depending on if you're male or female. In polycythemia, it hardly falls at all. So that can be a sign that you've got a lot of red cells there. So yes, the ESR is a non-specific test that isn't really used all that much, but it can be quite useful for monitoring flare-ups in chronic inflammatory conditions. So now we're going to go on and have a look at sideroblastic anemia. So this is the one, remember, that is both a disorder of iron access, if you like, but a disorder of iron restriction, but also a disorder of iron overload. So conditions that interfere with the production of adequate amounts of protoporphyrin, so that's the disc that surrounds the ferrous iron, can produce anemia, just as conditions where we don't have enough ferrous iron can produce anemia. So mutations that affect the first step in heme synthesis, which is the formation of aminolevulinic acid, result in sideroblastic anemia. So that's what causes it. There's lots of inherited and acquired conditions that result in sideroblastic anemia, but they all have these three things in common. They have an increase in total body iron, and we refer to this as iron overload, and they have the presence of ringed sideroblasts in the bone marrow. So once again, to diagnose sideroblastic anemia, you do need to do a bone marrow examination, because these ringed sideroblasts are definitive and diagnostic of the condition. And the other thing that they all have in common is a hypochromic anemia. So this may be microcytic, but again, it's classically dimorphic. So this is where we get this sort of dimorphic picture that you see here. So we have two populations of erythrocytes present, hypochromic and normochromic. And so the MCV can be normal, but of course the RDW is going to be increased, and the MCH may or may not be low, depending on how large that hypochromic population of cells is. You also get numerous inclusions in sideroblastic anemia, and this is where we see our famous Pappenheimer bodies on the blood film, on the peripheral blood film, and it could well be Pappenheimer bodies that you're seeing in these cells here. This one here certainly looks like it's Pappenheimer bodies. So what's happening with these ring sideroblasts is that because the iron can't be incorporated into the heme disc, so into the protoporphyrin ring, that procedure happens in the mitochondria. And so the mitochondria have this iron sitting in the cristae waiting to be incorporated into the heme disc, and it's not happening. And so we get, and we're staining up with our Pearl's Prussian blue stain, we're staining up the hemosiderin that's sitting in the mitochondria there, or the iron actually that's sitting in the mitochondria. And of course, mitochondria tend to form a ring around the nucleus of the macrophages. And so that's where the term sideroblastic anemia comes from. So these siderotic granules, they're called, that ring the nucleus of the macrophages in the bone marrow. So as I said, the ring thing, sure. Okay, so what happens is, because we've got an enzyme defect, so what's happening is that I can't remember the name of the enzyme, but it's an enzyme that helps with the formation of aminolevulinic acid, and so that is the first step in forming the protoporphyrin ring. And because that enzyme is not there, there are reduced amounts of ALA, aminolevulinic acid, and therefore we get reduced amounts of the protoporphyrin ring being formed. And even though we've got lots of iron there, because we don't have iron deficiency, there's plenty of iron, but because the protoporphyrin ring hasn't been formed, then there's no ring to insert the iron into. And that procedure of inserting the iron in the ring happens in the mitochondria of the bone marrow macrophages. Okay, so these are the bone marrow macrophages here, and these granules of iron are sitting in the mitochondria, waiting to be incorporated into the protoporphyrin ring. And so because we've got this abundant iron that's just sitting there, that is what we're staining up with our Pearl's Prussian blue. mitochondria in cells tend to accumulate around the nucleus. Certainly they do in this instance. And so because they're full of iron and we're staining the iron, we get this ring of iron around the nucleus. And these cells, these macrophages, are termed ringed sideroblasts because these iron granules, they're known as siderotic granules. And so that's why they're called ringed sideroblasts. Okay, beautiful. All right, so as I said, there are a lot of different causes of sideroblastic anemia. Some of them are hereditary, some of them are acquired. This is basically just telling you what we talked about on that slide there. So I don't know that we need to go into this anymore. So hopefully that will help you. So as you can see down the bottom here, ring sideroblasts do not develop into. So I do apologise. I presume these were the macrophages, but in fact they are the immature erythrocytes. So that involvement into the iron actually happens in the immature red cells. So I do apologise for that. And you can see that because of these, the iron not getting into the crista, into the protoporphyrin ring, our erythrocytes do not develop, and so we also get ineffective erythropoiesis. So this means that they are phagocytosed before they leave the bone marrow. And so we have reduced amount of mature red cells that are being produced, and that gives us an anemia. And because we've got ineffective erythropoiesis and we've got anemia and we've got tissue hypoxia, of course, the homeostatic response to that is to produce more erythropoietin to stimulate the bone marrow and also to suppress hepcidin so that we get more iron being absorbed from our diet and more iron from the macrophages being sent to the bone marrow for use in these developing red cells. And so we end up with this iron overload situation. So you can see there's lots of things that can cause sideroblastic anemia. It can be hereditary, it can be acquired. And we've already talked about lead poisoning causing sideroblastic anemia when we're talking about hypoproliferative anemias. We've also talked about the effects of alcohol. So not only does alcohol suppress the bone marrow, but it can also inhibit the enzymes that are used for heme synthesis. So it's a different enzyme to the ones that we see in the hereditary forms, but it still ends up with the same situation. Myelodysplastic syndromes we'll be talking about in the second half of the semester. So these are conditions where there's something is happening within the bone marrow and we don't get normal myeloid maturation. And so that's why it's called myelodysplastic. So there's a dysplasia or there is an abnormality within the formation and the maturation of the cells. And so you can see here there is a myelodysplastic MDS with ring sideroblasts. So you can see with the hereditary forms here we can have an X-linked form and an autosomal recessive form. These inherited forms are more likely to present with microcytic hyperchromic anemias, but the dimorphic blood pictures are quite common because only some of the hemopoietic cells may be affected. And so you've got an affected clone and an unaffected clone. And so the affected clone will make you your normal, the affected clone will end up with microcytic hyperchromic cells. The unaffected clone will give you normal looking cells, and that's why you get a dimorphic blood picture. You can see here that the cells are actually quite small in this case here. So we've got microcytic hyperchromic cells, but we've also got macrocytes as well, so, or reticulocytes. So the normal bone marrow that's functioning, or the normal clone, the normal hematopoietic clone that's functioning, is being stimulated to produce or to release red cells earlier because of to try and alleviate the anemia and the tissue hypoxia. And so we get early cells being released, so we get increased number of reticulocytes in the blood. So you can get a dimorphic blood picture, so normocytic, normochromic, microcytic, hyperchromic, or macrocytic. So you can get a combination of all of these things. And because it's the red cell production is being affected, the hemoglobin and the red cells are both low. White cell and platelets can be normal or low depending on what else is happening at the time. And again, with our sideroblastic anemia, because we've got this iron dysregulation, we can have Pappenheimer bodies in the red cells. And remember, we can see the Pappenheimer bodies in our normal MGG stains. And we can also see this punctate basophilia. I don't know if I talked about that when we were talking about lead poisoning earlier in the semester. So it's just another form of basophilic stippling, but it's a little bit more coarser than the basophilic stippling that we see in our, I don't know, where's that slide gone? Yeah, it jumped over this slide for some reason. It's a little bit coarser than the basophilic stippling that we see. No, it's coming up in thalassemia, in beta thalassemia. So these are the clinical features that we see from lead poisoning, just as a reminder. So we can get hyperactivity and low IQ and impaired growth in children, and signs and symptoms of anemia in adults. And this is where environmental history and employment history are really, really important. So for example, in Australia, in a place in South Australia called Port Augusta, there is a lead processing plant there, and so they are always monitoring the levels of lead in the people who work at the plant, but also in the community as well. And so the laboratory features, as we said, we get this dimorphic blood picture, and you can get what we call dual red cell histogram peaks. And so that shows us that we've got two cell populations there, and this punctate basophilia, which is here. This is the slide I was looking for. So here's the punctate basophilia here. It looks very much like basophilic stippling, but as I've said, it's a lot coarser and darker than we see with our in our beta thalassemias. So bone marrow examination, as I said, is the diagnostic tool for sideroblastic anemia, and you're looking for these ringed sideroblasts. And of course, we don't see these, well, we do see the sideroblasts in iron deficiency anemia, but they're markedly reduced, as you can see. These ones, usually you'd get only one or two little dots of iron around a nucleus, but with sideroblastic anemia, you get a lot, as you can see here. And that's the defining feature. Right, yep. So when we look at treatment for sideroblastic anemia, we can see it's quite interesting. If, of course, if it's acquired, it's a bit like our drug-induced anemias. Yes, so that is it. So the definitive test for sideroblastic anemia is to take a bone marrow examination and to stain the bone marrow with Prussian blue stain, and that's how you see the ring sideroblasts. So it stains up the iron that's in the ring, that's in the mitochondria. And just finishing off, I've just noticed what the time is. It's about time we had a break, isn't it? So sideroblastic anemia, as I said, the acquired forms of sideroblastic anemia, if it's caused by chemicals or alcohol, then if we remove the offending agent, usually the bone marrow will bounce back quite well. If it's hereditary, it's really quite interesting. Because it's due to a lack of a particular enzyme, then we find that it's if we can increase the amount of cofactor that is necessary for the formation of ALA to take place, then we can actually stimulate more heme production. And so pyridoxine is the cofactor in this first step. And so by giving pharmaceutical doses, so giving higher doses of pyridoxine than are normally found in the body and that are normally sufficient for this for porphyrin synthesis, if we give increased amounts of pyridoxine, we can actually stimulate heme production that way. So it doesn't fix the problem, but it certainly maximizes the amount of hemoglobin that's being produced. And the other thing that needs to happen when we get these cases of iron overload is using what we call a chelating agent. So desferrioxamine is the chelating agent that's most commonly used. And this is administered subcutaneously, and then it gets very slowly released into the bloodstream, and it actually complexes or chelates the iron that's in the bloodstream, so the serum iron or the plasma iron, and then it is excreted from the body through the urine. And the reason that we get this iron overload is because we get the same homeostatic response to sideroblastic anemia as we do to iron deficiency anemia, and that is by increasing iron absorption through the gut. And so we need to remove that excess serum iron in the case of sideroblastic anemia, because we can get all sorts of issues with iron overload, as we shall see after we come back from a break. So here we've got comparing of our differentiating results. So finally, we've got iron deficiency anemia, anemia of chronic inflammation, sideroblastic anemia, and thalassemia. So the thalassemia trait, which will may very well give us microcytic hypochromic anemias that need to be differentiated. And you can see here that the serum iron, total iron binding capacity, and serum ferritin are very useful ways in which we can do that. And then, of course, we've got hemoglobin electrophoresis, which helps us to identify our thalassemias. And again, this is the red cell count. Again, you can see that the red cell count in thalassemia, just to highlight that particular pattern that we can see in thalassemia of small red cells and a low hemoglobin, but often an increased red cell count, whereas in the other conditions we have a reduced red cell count in proportion to the degree of anemia. And so that's very, very important to keep in mind. I've got one more learning checkpoint and then we'll have a rest, because I need to go and get a drink. And I'm sure you guys could do with a rest too. Okay, so Pappenheimer bodies can be seen in thalassemia, sideroblastic anemia, lead toxicity, iron deficiency anemia. So choose all that apply if you can. Doesn't look like you can choose any more than one. Oh, that's annoying. Yes, because the answer is, of course, okay, so choose the one that it doesn't apply to. Choose the one where we don't see Pappenheimer bodies. So yes, so we see Pappenheimer bodies in sideroblastic anemia and in lead toxicity, and we can also see them in thalassemia as well, although it's really basophilic stippling that we see more so in thalassemia. So iron deficiency, we do not see Pappenheimer bodies because, of course, iron deficiency, there's nothing wrong with how the iron's being incorporated into the heme. There's nothing wrong with the globin chains and how they're being produced. It's just the fact that we don't have any iron present. Okay, so if we take a break now and come back in about, let's see, it's 4:21, so we come back at 4:30. Okay, so I'm back again, and just for the last half hour, we're going to have a look at iron overload. And so, as we've previously described, homeostatic mechanisms store and recycle iron rather than excreting it. And in fact, we don't have a homeostatic mechanism to correct iron excess, only iron deficiency. And you can see from this list that there are two major um, instances where we can get iron overload, inappropriate increase in intestinal absorption, and we've just been talking about sideroblastic anemia, so that's an example of an iron loading anemia. There are others there. Hereditary hemochromatosis that we'll look at in a minute, and then the other general group where we get iron overload is when we have an increased transfusion load. So we've already talked about iron overload as being a consequence of transfusion-dependent thalassemia, and this is because what happens is that we are bypassing the the usual enteral route, and it is that enteral route where we have the suppression mechanisms, which are the homeostatic mechanisms of the body that control iron um, being absorbed and reaching the plasma. So that's our whole hepcidin thing that's happening there. But if you bypass that and introduce iron directly into the blood vessels as in the form of a blood transfusion, then you are bypassing that homeostatic mechanism. And so anything where we have an increased transfusion load, any time when people really need regular transfusions to survive, iron overload can be a serious consequence of that condition and needs to be treated. So we're going to have a look at hemochromatosis first. And hemochromatosis develops due to mutations in genes that encode for the proteins of iron metabolism. Um, and what happens is that feedback regulation of iron is impaired, and so basically hepcidin is not stimulated. The production of hepcidin is not stimulated by replete iron body iron stores, and we continue to absorb iron even when our iron stores are full. It wasn't until the mid-1990s that a mutation was identified that in the hereditary hemochromatosis protein, and that's known as the HFE protein and the HFE gene. And shortly after that, there were additional mutations of the same gene that were identified. As further molecular testing was developed, we have what is a general hereditary hemochromatosis phenotype, and various genotypes are created by the mutation of any of the genes responsible for an iron regulatory protein. So we've got two main mutations here. We've got C282Y, which is where we get a conversion, a mutation of cysteine is being replaced by tyrosine, and an H63D where we have histidine being replaced by aspartate. So this one here, the C282Y gene, is the most common mutation that we find. And what happens is that the gene is only one of a number of factors that increase the risk of developing hemochromatosis. So unlike thalassemia, it doesn't indicate the inevitable outcome of it. So it just increases your risk. And this mutation, or these two mutations, and hemochromatosis itself, are the most common inherited disease of Northern Europeans. And so that's people from Scandinavian countries, basically. So we have the and also in the UK. So we have through the Mediterranean and the Middle East and into Asia, we have our thalassemias and our hemoglobinopathies, or our hemoglobin variants. And then in Northern Europe, we have hemochromatosis. Even though it says here that the gene frequency is 1 in 300, which is a fairly common gene frequency, the disease is not as common as that. So there must be a lot of heterozygotes that are around rather than the homozygotes. So you can see from this table that the different mutations in the HFE gene affect different population age groups, but we will be focusing on this first one because it was the first mutation to be described, and it is also the most common mutation. So you can see here that the age of onset of this particular mutation, which is the C282Y mutation, is the age of onset is 30 to 40. Now, this is where I attempt to explain to you what happens in hemochromatosis. So if we start off with when we have a normal HFE protein that's been produced by a normal HFE gene, and it's all to do with the interaction of the HFE protein and transferrin receptor 1 and transferrin receptor 2. Yes, you didn't realize there were 2 transferrin receptors, did you? So we have the biological default of homeostasis is that iron is absorbed. Sorry, there it is. Yeah, the default is to absorb and store iron, and so it is the regulatory processes such as hepcidin which actually help to block that absorption and storage. So we start down here with our normal HFE protein, and what happens in the cells of the body cells is that it binds to a beta-2 microglobulin, and then this compound makes its way to the cell surface, and it interacts with transferrin receptor 1. And so what happens is that HFE binds to transferrin receptor 1, and it's until a molecule of transferrin binds to it. And then once the molecule of transferrin has bound to it, the HFE part of this compound is released from transferrin 1 or transferrin receptor 1, and it goes around and then it binds to transferrin receptor 2. And this binding to transferrin receptor 2 initiates a signal for hepcidin production, and ultimately this reduces iron absorption. Okay, and then it sort of goes on. So every time we get this HFE protein binding to a transferrin receptor, then a message is sent off to the liver, so the liver can sort of tell how much iron is being absorbed by the cells. What happens in hemochromatosis, where we've got an abnormal HFE protein, it either doesn't bind to beta microglobulin, or I just need to, or it doesn't bind to the transferrin receptor. So if it doesn't bind with the beta-2 microglobulin, then the HFE does not reach the cell surface, and it doesn't bind with transferrin receptor 1. If it does reach the cell surface, then it doesn't bind with either transferrin receptor 1 or transferrin receptor 2, so we don't get this signal being sent off. So this is the problem. This signal is not being sent off. So regardless of why the HFE is not getting to the cell surface and not binding transferrin receptor 1 and then to transferrin receptor 2, the signal to the liver to stimulate hepcidin production is reduced. And without hepcidin, ferroportin in our enterocytes in our gut is continually active, and even when the body stores are replete. And also, of course, the iron is being absorbed into the cells too, because its transferrin is constantly binding and releasing the iron into the cells. And so failure of normal regulation leads to excessive absorption and excessive storage, and this is what causes hemochromatosis. And just a reminder that all forms of hemochromatosis are hereditary, whereas with sideroblastic anemia, we had that multiple causes which can either be acquired or inherited. So while this slide is entitled hemochromatosis, any situation of iron overload where we get that blocking of hepcidin, so we don't get the normal feedback mechanism to the liver, or that circumvents intestinal absorption, will have a similar outcome. So what happens normally, initially cells will store their excess iron as ferritin. So remember, ferritin is about 65% of the body cells iron storage, and it's the metabolically active form, so it's easy to get at, it's easy to use within the cell, and for the macrophages and hepatocytes, it's easy to then release to the circulation when it needs to be, when it's being recycled. So once, so 65% stored as ferritin, then about 35% is stored as hemosiderin. But what happens when the storage capacity is reached, then we get free ferrous iron in the stores. So we get this free reduced form of iron. And in the presence of oxygen, ferrous iron can initiate the direction of the production of superoxide and other free radicals, and this can result in the peroxidation of all membrane lipids. And so this just isn't the cell membrane, this is the mitochondrial membranes, it's the nuclear membrane, it's the lysosomal membranes, and of course this is not compatible with the continuing function of the cell, and we get cell death. And because all cells need iron, most cells have the potential for iron damage due to iron overload. And the tissues that are most obviously affected are the tissues that we can see, or the tissues that we can feel, or the tissues that give us some sort of pain. And so the ones that we usually see with our clinical signs and symptoms are the skin. And it says here that we can have a skin that turns a golden colour due to hemosiderin deposits. But often what happens is that people with hemochromatosis get quite a ruddy complexion because they've usually got really good red cell count, really good hemoglobin concentration. So you can actually get sort of this ruddiness to their, particularly to their cheeks, as well as this sort of bronzed looking skin as well. The liver is often affected, as is the pancreas and the heart. We can also get arthritis and our endocrine organs being affected as well. And so complications of iron overload include things like cirrhosis and diabetes, and also cardiomyopathy and the other conditions that I said there as well, so arthritis and hypogonadism and osteoporosis. So it's not good to have iron overload at all, and so it's much better if we can prevent iron overload from happening in those conditions where we know that it can be a complication. And unfortunately, hemochromatosis is one of those conditions of exclusion. And so because it presents with such vague symptoms, as you can see on this slide, often it's quite tricky to pinpoint and quite hard to diagnose. I'm just reading the notes that I've got for this slide, and sort of it goes through this list of symptoms here. And I've got here that so according to the Australian Red Cross Service, people with hemochromatosis can sometimes set off metal detectors. And that's true. Red Cross Blood Service would not lie to me. But that's pretty amazing, yeah. So we can get these vague symptoms that are very commonly associated with other conditions. So of course, you know, these palpitations and shortness of breath and chronic fatigue, you know, as soon as you see these, what's the first thing that you think of? Anemia, isn't it? So, you know, and then you do a full blood count and, you know, hemoglobin comes back and it's this really great, robust hemoglobin, and the red cell count's really great, and you think, oh, well, it's It's nothing to do with anemia, so it's nothing, it's not a haematological issue. White cells fine, platelets are fine. According to this full blood examination, this person is hale and hearty. But it's not really, it's probably a situation where our biochemistry tests are more likely to pick up the disorders, because we're going to be finding, abnormalities with the liver and the pancreas, and our other, and also perhaps even endocrine disorders, or, endocrine indicators as well. So it really is, as I said, it's more a condition of exclusion. So talking about the laboratory findings, we find that the blood film is normal, but if you've got somebody who is a bit on their game, then they may have the thought of actually doing iron studies. And so it is, again, it's our iron studies that can actually show us that we have got this uncontrolled absorption of iron. So everything is increased. So our serum iron is increased because we're keeping on absorbing it from the gut, and our total iron binding capacity is either normal or decreased because all of the transferrin that's there has been bound to, all the iron that's there has been bound to the transferrin. So we've got very little apotransferrin left that hasn't been bound to the iron. And of course, this means that our transferrin saturation is increased, and of course our serum ferritin is increased, because all this iron's just constantly going into the cells. And of course, it's bone marrow examination would show massive iron deposits. So this is actually a sample. Again, it's a bone marrow that's been stained with Pearl's Prussian blue to show the iron deposits. We don't often do a bone marrow in hemochromatosis, but I guess as a last resort, it may be something that you might consider. But usually iron studies, and as I said, other biochemical tests will probably show them better. And the definitive diagnosis is actually detecting the gene mutations. And as soon as you find a gene mutation in one family member, you check all of the other family members as well. Okay, so interpretation of more iron studies results. So you can see that these iron studies results really are quite useful. And so it behoves you to certainly incorporate them into your knowledge about the different conditions, particularly conditions around iron dysregulation, and conditions that need to be differentiated from conditions of iron dysregulation, such as thalassemia. So when we go and have a look at the treatment for iron overload, depending on what's causing it, the treatment is going to be different, and that makes sense. So when we have hereditary hemochromatosis, usually what the clinicians try and do is to induce a mild anemia, and the easiest way of doing that is to get the person with hemochromatosis to donate blood or give a blood donation. And so these people go down to the Australian Red Cross Blood Service, and they would have a unit of blood removed from them, so 600 mils of blood removed. And this is done on a fairly regular basis until they get a mild anemia is induced. And this makes sure that all of the iron that's in the body is going to be used, and that we don't have any abnormal stores of iron. The only trouble with this blood being withdrawn from the patient is that it can't be used for anybody else, because it's, the cells are genetically abnormal. Unfortunately, it has to be disposed of, which is very sad. And also, if there's any tissue damage, then that would get treated. If liver cirrhosis was bad enough, perhaps a liver transplant might be forthcoming. And if the pancreas has been damaged irreparably, then of course the person's going to have diabetes and will have to be treated for diabetes. If you've got transfusion-related iron overload, then obviously you're not going to withdraw blood from the person, because the person needs the blood. And so they were given the transfusion for a reason. So again, in these sorts of instances, the same as with sideroblastic anemia, what happens is that the person is treated with iron chelating drugs. So we've already talked about desferrioxamine, so that's the one that's administered subcutaneously. and now there are a lot more oral iron chelators coming on the market, so it's just they're easier to take than, of course, having to have a subcutaneous injection. And these have their side effects, but of course these are the only ways that we can reduce or keep iron levels within the body from getting too high. So these chelators all work in the same way. So they are absorbed slowly into the body because it's in that slow absorption that they work best and that they chelate with iron the best, and then they are excreted in the urine. So the chelator plus the iron are excreted in the urine. And just to finish off with, there is this summary slide that it may be a little bit hard for you to see here, although it seems to have come up quite well. And again, it's directly from Mackenzie. So Mackenzie chapter 12 is really good. I highly recommend you go and see it. Lots of summary tables and things for you to have a look at. So you can see here that we've got iron deficiency anemia, anemia of chronic inflammation, sideroblastic anemia. So what we see in the full blood count and iron studies and any other information that might be useful. For some reason, my pointer's stopped. That was fun. Okay, so oops. So we've got summary slides. So that's for you to fill in as usual, and then sorry, that's a summary. That's individuals at risk of developing iron deficiency and overload. So that's for you to summarise on that slide. And then we have the summary of the presentation here. And as usual, some review questions for you to have a look at. And that's it for now. So has anyone got any questions? Okay. Well, thank you very much for listening. And thank you very much for hanging in there. And I'll talk with you again tomorrow if there's nothing that anybody else wants to talk about at the moment. Yeah, that's it. Okay. See you tomorrow.